Manpreet Kaur. Yeah. So we have a chemotherapy-related endogenous endophthalmitis. I'm sorry for that. Yeah.
So, good afternoon, everyone. I have a case report on chemotherapy-related endogenous endophthalmitis. Coming straight to the case report, a 44-year-old woman presented to us. She had a hepatocellular carcinoma and presented to us with painless gradual deterioration of vision in her right eye for 2 weeks. The patient was non-diabetic, non-hypertensive, and she received 10 cycles of chemotherapy, atalizumab and bevacizumab, along with radiation therapy for the hepatocellular carcinoma. Her last chemo session was 4 weeks back, and her best corrected Snellen visual acuity was counting finger 2 meter in the right eye and 6.6 in the left eye. Slit lamp examination of the right eye showed grade 1 AC cells and mild vitritis. On fundus examination of the right eye, there was a yellowish white focus resembling subretinal abscess over the macula with normal retinal vessels and disc. Left eye fundus was absolutely normal. IOP was normal in both the eyes. We did OCT, and to our surprise in the right eye, it showed a hyperreflective area in the inner retinal layers in the foveal region. So this is the right eye fundus picture. The optic disc, the vessels, and the periphery were absolutely normal with a single foci in the macular region. This is the OCT picture. We can appreciate the hyperreflectivity in the inner retinal layers. So we did complete systemic examination including CBC, DLC, which revealed mild neutrophilia. QH examination of the vitreous tap was done that showed a few fungal hyphae, whereas the gram stain was absolutely normal. And a vitreous tap was taken and sent for culture. Blood culture for bacterial and fungal growth were negative. On the basis of QH examination, we give intravitreal vancomycin 1 mg per 0.1 ml, ceftazidime 2.25 mg per 0.1 ml, and voriconazole 100 mg per 0.1 ml in the right eye. Patient was put on oral tablet itraconazole 100 mg twice a day for 14 days after the oncology opinion, and topical antibacterial and antifungals were administered. After 2 days, the vision improved to finger counting 4 meter from finger counting 2 meter. And on fundus examination, there was a significant reduction in the size of the subretinal abscess. We did repeat OCT, which showed a reduction in the size of the hyperreflective material over the macular region. Intravitreal voriconazole was repeated 2 days after the initial dose, along with vancomycin and ceftazidime to take care of the bacterial infection as well. Vision, fundus examination, and OCT were done after every 2 days, which showed marked improvement. After 10 days, her vision improved to 6/9. AC cells and vitritis were completely resolved. The left eye was examined on every follow-up visit. After 4 weeks, the vitreous culture examination came out to be positive for Candida species. So this is 10 days after the initial dose of vancomycin, ceftazidime, and voriconazole. This is the OCT finding of the right eye. There is reduction in the hyperreflective material in this. So coming to the discussion, this case report describes a case of fungal endogenous endoph in the context of intravenous chemotherapy. Risk factors for endogenous endoph in this case are compromised immune system and the use of IV catheters for chemotherapy. Among bacterial, gram-positive, staph and strep2 are the most common causative agents in the Western countries, whereas in Asian ones, Klebsiella is the most common organism. Among fungus, Candida albicans is the most common cause of fungal endophthalmitis. In this case report, the culture was positive for Candida. So endogenous endoph is mostly unilateral, but 1/3 of cases can have bilateral involvement as well. The infectious agent travels through the bloodstream and multiplies in the choroid, eventually infiltrating the retina and spreading into the vitreous. The organism spreads through the internal ocular tissue through the blood-ocular barrier. So the take-home message, it is an ocular emergency and any suspected patient should be treated promptly. Assessing the extent of ocular involvement, identifying the causative organism and the underlying source of infection, and treating both the endoph and the underlying systemic infection are the steps in the care of such a patient. In high-risk individuals, an early diagnosis of endogenous endoph could avert irreversible vision loss. Thank you so much.
Thank you for that interesting case. And as the last one, you get the golden question to be asked. How frequently do you repeat this voriconazole intravitreal injections?
So not in every patient, but depending upon the duration of symptoms.
No, I'm asking per patient. How frequently would you re-inject the voriconazole?
After 48 hours.
After 48 hours?
Yes.
And do you know what is the half-life of voriconazole in the vitreous?
Not exactly.
So you can look that up because there is another agent.
One second.
Yeah.
I'll repeat the injection twice. But even after the second injection the patient is not improving, then I'll go for vitrectomy straightforward.
Yeah, that is about the repetition. So the important thing to remember is voriconazole has a shorter half-life, about 8 hours or so.
Okay.
So you might need to repeat it every day, and in
Okay.
some patients initially twice a day also.
All right.
So amphotericin B is another option which lasts longer, and it also works well for other fungal species. Right? Thank you for that case presentation. If we have no more doubts.